Good afternoon. My name is Lisa Sopko. I am the manager of community programming at the Epilepsy Association. I'm pleased that you could join us for our August seminar, and I'm glad you could join us for this online presentation. Just a few housekeeping items before we get started. Today's program will last about 60 minutes, including a brief Q&A session at the end. Please make sure your computer, microphone, and phones are muted at all times as this program is being recorded. If you have a question, please use the chat feature in the bottom right of the Zoom page. We'll get to those questions at the end. The recorded seminar will be posted on our YouTube channel to view later on in the afternoon. Additionally, I would like to take a moment to thank our program sponsor, SK Life Science. Their generous support has helped us underwrite the cost of hosting today's program. Please visit our sponsors' websites or contact the local rep directly. This information will also be shared in a post-seminar email. Now, I'm honored to introduce today's speaker, Dr. Martha Sajatovic at University Hospitals. In today's seminar, you will learn about epilepsy self-management and the SMART program. I would like to turn the program over to Dr. Sajatovic so she can present on this important topic. So welcome, and look forward to your presentation.
Thank you, Lisa,
You're
and
welcome.
thank you to the Epilepsy Association for inviting me and allowing me to talk about one of my favorite topics, which is the SMART Epilepsy Self-Management Program. As Lisa noted, I'm Martha Sajatovic. I'm a neuropsychiatrist by training, and I have been at Case Western Reserve University School of Medicine and University Hospitals Cleveland Medical Center for several decades. And one of my areas of interest, so I'm a clinical researcher, but I've always been interested in how can we use research to improve people's lives right now, right here, today, not 15 years from now or 20 years from now or 50 years from now, as we think about for drug discovery and other types of basic research. And that's really important. Don't get me wrong on that. I think we have definitely a role for new discovery of treatments for epilepsy and other disorders of the brain. But I personally have always felt that helping people to help themselves is a really critical and yet underrepresented and understudied area in research. So that's what I chose to focus my efforts on starting probably 12 to 15 years ago, and developed a program called the SMART Epilepsy Self-Management Curriculum. So that's what I'm going to be talking about today. I'm going to go through some slides. What I would say is I will try to finish up a little before the hour to take some questions. If you do have questions, I would say go ahead and put them in the chat. And that way, hopefully I can get a chance to address anybody's comments or queries. So let me share. I was able to do this in the beginning. Let's make sure I can do it now. So are you guys able to see that slide? So it should take up your full screen. Okay. So epilepsy self-management for people with a history, epilepsy and a history of negative health events. And so I like to talk about what I call the science to service model. And you hear about what that is in just a minute. Oh, I'm not able to advance here. Let me see. Okay. So I don't need to spend a lot of time with this group explaining what epilepsy is, but we know that over 1% of the total US population is affected. That translates to close to 3.5 million people nationwide, and almost 500,000 children, around 3 million adults. We do know that epilepsy can have an onset across the full lifespan. A lot of the work that I've been doing has been in older people. So events that cause brain injury like stroke or traumatic brain injury can, also indicate the onset of epilepsy. Just to put things in perspective, and this is where I get kind of fired up when we think about, research funding across the United States or agencies that work to help improve the lives of people with these conditions. So you hear a whole bunch about breast cancer, the pink ribbon and all of that stuff. right? So breast cancer affects 4 million people in the US, epilepsy, 3 million, like pretty darn close, right? And I can tell you that there's kind of no contest when you look at the funding and the attention that it gets, right? So I don't mean to diss or minimize the importance of breast cancer by any means. That is a serious problem that we definitely need to support individuals dealing with breast cancer and challenged with it and come up with all different kinds of cures. But I would make the argument that uh, epilepsy, by contrast, is way, way, way underfunded and way, way, way undersupported. So that just gives you some numbers to chew on. And actually, if you look at the bottom one, deaths per year, epilepsy surpasses breast cancer. So again, I think that just sort of underscores the under recognition and under support that we have. So epilepsy self-management is defined as the things or processes that people use to control seizures and manage the effects of epilepsy. So what can a person do for themselves? Most of the evidence-based approaches that we have currently are developed from what's called the chronic illness self-management model, as is the SMART program. It is a model that works and has been adapted for a variety of different health conditions. Interestingly, and I get asked this sometimes, is can epilepsy self-management have biological effects? And I would make the argument that yes, it can, and not just behaviors and quality of life, but also biomarkers. So if we look at chronic disease self-management, we see that stress hormones are reduced, markers of cellular inflammation, and even things like heart rate variability, right? So if any ever been startled or in a car accident or had something bad happen to you, you've noticed that very uncomfortable feeling of feeling like your heart is beating really fast and you're kind of feeling sweaty. And that's a marker of what we call autonomic instability. So your body is responding. And there is emerging evidence to suggest that effective self-management programs can actually have an impact on that autonomic nervous system and all the biomarkers that are associated to that. So it's not just, talking to make yourself feel better, but it's really implementing a program that can have wide-ranging biological effects. In spite of the benefits for ESM, or epilepsy self-management, there are a bunch of barriers. These are just a small sub-list of the barriers that can impede people being able to take care of themselves and manage their epilepsy most successfully. So forgetting is common. Epilepsy anti-seizure drugs sometimes are multiple times a day to be taken. That's hard to remember. Sometimes medications don't work as effectively as would be optimal. Side effects are very common. Almost every single medicine has side effects. Sometimes they're very burdensome and sometimes they're mild, but they're still there. Depression or other mental health symptoms are very common in people who have epilepsy. And that's kind of linked to stigma, which is pervasive societal reactions to people with epilepsy. Unfortunately, stigma is alive and well in our society with respect to epilepsy. Lack of social supports and lack of access to care or medications. So we recently finished a project, and I'll talk to you about that more in a minute, but for example, people living in rural settings, right, might have to drive a long way to get to go see a clinician or get medical care. And that's hard if you're having active seizures and may not have your own transportation that is practical and easy for you. Having epilepsy is a stressful condition. One of the things that makes epilepsy particularly difficult is that when a person is going to have a seizure is often unpredictable. Some people have auras, but not many. The greatest proportion do not. And people with epilepsy have 2 to 5-fold increased risk of developing any type of psychiatric disorder. The most common psychiatric comorbidity is depression, but also anxiety. But there are other conditions like bipolar disorder and schizophrenia that are more likely to occur in people with epilepsy compared to the general population. And generally, 1 in 3 people with epilepsy will have a lifetime psychiatric diagnosis where they will fill clinical criteria for having a comorbid psychiatric condition. The research data that's out there on outcomes in people who have epilepsy plus a comorbid psychiatric condition is that they tend to respond not as well to treatments such as drugs or even epilepsy surgery, and they have increased morbidity, so types of complications, and unfortunately premature mortality compared to people with epilepsy who do not have psychiatric comorbidity. So that is another reason why it's particularly important that folks with epilepsy get self-management curricula, and that we prioritize curricula that will address mental health problems or comorbidity. Since 2009, I've been part of an organization that I've been very proud of. It has been one of the high points of my professional career. It is the CDC-funded Managing Epilepsy Well, or MU Network. Here's a picture of our team a few years ago at one of the National Anti-Epilepsy Society meetings. The mission of the MU Network is to advance science related to epilepsy self-management by facilitating and conducting research in collaboration with network and community stakeholders, in addition to broadly scale up these findings so that the number of people with epilepsy possible can get access to and potentially benefit from epilepsy self-management programs. So I'd be telling you what science to service is. So here's what it is, and it's this is a slide developed by the CDC's epilepsy program that I think is marvelous, and it shows how those of us involved in this science of epilepsy self-management work and conceptualize developing the programs and then making them available to as many people as possible. So in the box to your left, you see the research and program development. So every evidence-based epilepsy self-management program developed by the MU Network, including SMART, went through a rigorous development process to make sure that the program is practical, that people with epilepsy would find it acceptable and relatively easy to use, and that the benefit exceeded the burdens of being in the program. So many of us, including our SMART team at Case Western, have spent quite a bit of time making sure that the program is a good fit for people with epilepsy. Then we go through the process of evaluation. So we would do randomized controlled trials, which is a gold standard in intervention development, whether it's drugs or behavioral treatments. You need to show that this intervention works, and on what outcome. So we have taken the time to very rigorously test these interventions. Then we disseminate them. We find people in the community who are interested and willing to adopt our programs. And then we do another round of evaluation to see if they work in real world settings. And then we look at things like cost benefit analyses, reimbursement, and cost studies. So can we not only build these systems, test them rigorously, but can we scale them up in the community and show that they have public health benefits? So that's the science to service model. And we have taken the SMART program through that cycle. The MU Network has developed a number of programs. The SMART program is not the only game in town. So if you go onto the CDC's Managing Epilepsy Well network, you can read about programs that others of my colleagues have developed, like the Hopscotch program, Project Uplift, of course, SMART, that I'm going to tell you more about, a program called PACES, a program called Mindset, and then also a program that our case team developed a number of years ago called Time. I would say we're not doing Time very much these days, but we have taken many of the successful elements from the Time program and inserted that into the SMART program. So just talking about the Time program, this was our original program. So we originally developed Time as a project for people with epilepsy who also have comorbid mental health conditions like depression or bipolar disorder. We spent almost a year kind of refining the program. We had a community advisory board to help us develop the program. And then we did a pilot project that included 44 people with epilepsy who had comorbid serious mental illnesses like major recurrent depression or bipolar disorder or schizophrenia. We conducted a randomized controlled trial where we compared the time program compared to treatment as usual. And our primary outcome was depression severity measured using validated standardized rating scales for depressive symptom severity. In that study, which was published in 2016 in Epilepsy and Behavior, we, as I said, enrolled 44 people. The average age was close to 50. The majority were people who were challenged on the annual income and not being employed. We did find in the outcomes that there was a significant effect for depressive symptoms as measured with the Montgomery-Åsberg Depression Rating Scale or MADRS rating scale. It had an effect size of 0.7, which is a large effect size, with lower MADRS at 16 weeks in people that were randomized to time compared to those who were in treatment as usual, where they had no change in depressive symptoms at study endpoint. Then, kind of going along with our science to service model, I worked with the Epilepsy Association here in town to get some funding from the Adams Board, the Alcohol, Drug Addiction, Mental Health Services Board, to offer epilepsy self-management to adults with epilepsy. So that was a successful effort. One thing we did find when we were implementing the time study is some people, actually a lot of people with epilepsy, might not necessarily have a clinically diagnosed psychiatric condition, but they certainly did suffer from depression and anxiety symptoms, and they had their epilepsy. So what we wanted to do was expand our program, available more broadly. So we included anybody with epilepsy who's been having recent epilepsy complications. And then the other important pivot is the time program was delivered in person, and that was really hard for people who may not drive or have easy transportation access. So we developed the SMART program using a lot of the same curricula items as time. This was 8 group format sessions delivered in a web-based format. We used posters and graphics and handouts that emphasize interactive discussion. Because we know not everybody has easy or consistent web access, we also provided and made available telephone call-in available for those with limited internet access or familiarity. The group sessions are conducted over a period of about 8 to 10 weeks, and we have a detailed curriculum. The bottom bullet point is the secret sauce. So the SMART groups are co-led by a nurse and a peer educator. A peer educator is a person with epilepsy who's trained in the SMART curriculum and knows how to deliver it in collaboration with our nurse. So these are peer educators. They serve as guides to support participants. They have personal experience and are willing to share their experience, including how they may have struggled with behavior changes and what they learned. Peer educators are not meant to be perfect model of health, but can help people in the SMART groups realize that you're not alone. Sometimes learning self-management skills takes time. However, investment in yourself can have a very high return on investment. And one of our mantras in the SMART program is that we often learn more from our mistakes than our successes, right? And so that ability to share can be very, very helpful for people in the group. This is a quick overview of the types of topics that are covered in the SMART curriculum. So as I mentioned, we have 8 sessions, and the discussion points, as you can see, are not all about the seizures, right? People with epilepsy, having seizures is one part of their life, but definitely not their whole life, right? So we talk about myths and facts about general epilepsy management principles, but also important things like managing stress, managing stigma, managing something called double stigma. So if you have depression and epilepsy, both depression and epilepsy can be very stigmatizing conditions. So you can actually have a pretty high stigma burden if you happen to have both of those conditions. We talk about problem-solving skills, the importance of daily routine and good sleep, how to communicate with your healthcare providers. People with epilepsy spend a good chunk of time seeing doctors and clinicians. And there are ways that we can help support people to communicate and get your questions answered and your needs met. We talk about nutrition for best physical and emotional health, stress management approaches. We dive into medication routines, how to prioritize discussing side effects with your clinicians, using your available social supports, and advocacy and support groups for epilepsy, including important groups such as the Epilepsy Association. And then last but not least, normalizing your life in spite of having a chronic but unpredictable condition. So self-management is not an event. It's a process. It's part of a healthy lifestyle. It takes practice. It takes work to get good at it, but it can be learned, and people in our SMART program can benefit from the support of others in learning self-management skills. So I want to take a couple of slides here to just give you an example of some of the curriculum items in the SMART program. So we use something called the IDEA approach. IDEA is an acronym, and it stands for several steps that you can use to solve health problems, including problems related to epilepsy. But we often don't tell people, it doesn't have to be an epilepsy related problem that you're working on. It could be related to another health condition, or it could be related to a problem that doesn't even directly impact your health. So these are the steps. I stands for identify the problem. What is the problem? What's keeping you from doing or getting what you want or need? So an example might be, I forget to take my morning blood pressure medication because I have to be at work so early and I have too much time, too much going on in the morning. So that's my problem that I've identified, right? My blood pressure is high, and I'm supposed to be on a medication which works to reduce my blood pressure, but I just forget to take it from time to time. So the next step is to define the possible solutions. So in this stage, we recommend people to all possible ways to solve the problem. This is not the stage to judge your possible solutions, just, free association, write them all down. So as an example, going back to problem of my blood pressure medicines, possible solution was, I could take all my medication at bedtime. That's one idea. I could talk to my doctor about giving me a medication that only needs to be taken once a day. Or I could just give up on my medicines completely since my blood pressure was okay the last time I checked it at Walgreens. So this is just an example of 3 possible solutions. And then we provide people with worksheets where they can write these things down. So the solution. And then that leads into step 3, where we ask people to identify the pro and the con of each of those solutions that you just came up with. So thinking about solution, one, could take all of my meds at bedtime. That would be easier to remember, but maybe I would be too tired in the morning. Maybe it would make me oversleep. I could talk to my doctor about giving me a medication that only needs to be taken once a day. That could be easy to remember and might even work better, but I don't have a doctor's appointment for another couple months yet. Although maybe I could get one sooner if I called. Or option number 3 that I came up with, just give up. That's probably the least hassle, but my blood pressure could go up again if I stop cold turkey on my medicine. I might not notice it because I don't really feel it necessarily when my blood pressure is high. And I heard that somebody in my group had a heart attack when he missed his medications for a few days. So, and then step 4 is to act on the best solution. So looking at the pros and cons and coming up with the best choice. Solution number 2 looks like it might be the best trade-off in terms of pros and cons. So that might be the choice that you try first. And if that doesn't work, you might want to go back to your list and see if there's another. So as I said, we give people handouts, and this is an example of one of them. During the SMART groups, people walk through, or the peer educator might walk through how they either have used the IDEA approach or might be planning to use the IDEA approach going forward. So the idea here is to get some group discussion and test drive it a little bit. And we ask people for their homework to try and think of a problem that they have in their life that they might be able to try the IDEA approach on for size. All right, let's go back to our science to service and the science part of it. So we did a randomized control trial testing SMART compared to a treatment as usual. Our primary outcome was epilepsy complications. So that was negative health events, or NHEs. NHEs were defined as a seizure, a hospital visit, emergency room visit, or a self-harm attempt. So if any of those happened, we counted them, one through whatever. And what we found is that in the SMART group, we had a 82.4% reduction in NHEs compared to waitlist that had a 59.6 reduction. So that was a significant improvement. And change in total of NHEs went down over 10 points in the SMART group compared to not quite 2-point reduction. So we saw a significant improvement in epilepsy complications. Other secondary outcomes we tested in the SMART program was an instrument called the 9-item patient health questionnaire, or PHQ-9, which was depression severity, and then the Montgomery-Åsberg depression rating scale, which is another rating scale for depression, as well as the 10-item quality of life in epilepsy. And I can tell you that all 3 of those outcomes were improved in SMART compared to waitlist over the course of 24 weeks. And so that was both a clinically important as well as a statistically important improvement in a variety of important health outcomes. So we were encouraged by that, but that was done in a academic medical center by our research team, and we were interested in doing a second replication study to see if we could find the same good outcomes if we did this in more of a real world study. So we got some funding from the CDC to conduct what's called an effectiveness randomized control trial, or effectiveness RCT. We did an 18-month prospective trial where we compared waitlist SMART versus 6-month waitlist. We enrolled people with epilepsy from 2 different in Iowa and in Ohio, so it was a multi-site study. We prioritized people from underserved and rural settings. I told you a little bit about the format of the program. So it's 8 groups, about an hour-long sessions, up to about 10 people, and co-delivered as always by the nurse and peer educator dyad. We did some phone follow-up in this in our SMART 1 and SMART 2 trials, where the nurse would follow up with people by phone afterwards. The folks that we enrolled in this effectiveness trial is adults with epilepsy. So up until now, we have not tested SMART or refined SMART in kids or adolescents. I get asked all the time, when are you going to do that? Gosh, I want to do it like yesterday. We are still trying to get funding for a trial in adolescents. So we're still trying to work on that. As some of you may realize, this is a challenging time in academic research. So we're not giving up, but for right now, we're not running a trial with kids or adolescents. Going back to our SMART trial, everybody who was enrolled had at least 1 negative health in the last 6 months, either a seizure, hospital visit, ED visit, emergency department visit, or a self-harm attempt. They had to be able to provide written informed consent in English, because the program currently is delivered in English. We also have explored adapting SMART for a Spanish-speaking audience, and I think that would be good to do where we are in Northeast Ohio. Again, something that I hope to be able to seek support and funding for in the future. Now, this slide's a little bit busy, so let me give you a background on it. So, as I said, we were prioritizing people who lived in rural settings or underrepresented groups. And so we used the U.S. Department of Agriculture's Rural and Urban Continuum, or RUC code. RUC codes are coded from a 1 to 9 continuum. 9 is the most rural, 1 is the most urban. So this slide shows you the states of Ohio and the states of Iowa and the color coding. So it's most rural, and you can see where the codes are going. If you look at Ohio, we don't have very many of the more urban or the more rural counties. We do not have a Rook 9 in the entire state of Ohio, and we only have one Rook 8. Compare that to Iowa, which has a lot more rural settings. And that's, I think, why it's really important when you're doing clinical trials to expand outside of the, your initial stomping ground. So if you look at state of Ohio, the counties that are closest to us here in Cleveland are a Rook 3 or higher, so they're more urban. All right, this is where we enrolled people. As you can see, we enrolled people all across the state of Ohio. The blue pointers or the blue pins are individual participants with epilepsy that were enrolled by our Case Western team, and the yellow pins are those that were enrolled by our colleagues in University of Iowa. But you can see we covered the entire US. This is the sample description. So the average age was just under 40. They were a little younger than our Smart 1 sample. More women than men, about 2/3 women. Unfortunately, that's a common finding for us. We have a hard time getting men with epilepsy to participate in our programs. I think, what we hear again and again across the MU network in general is that women tend to be a little bit more comfortable in interacting with these kinds of groups. But we do continue to really prioritize trying to include men into the programs. I want to just call your attention to the income. So over 40% of our people had an annual income of under $25,000, and many of them fit under the federal poverty line. So definitely under-resourced for most folks. And as I mentioned, we were trying to prioritize people from rural settings. We did pretty good with that. So we had almost 20% who had a Rook of 6 to 9, that very most rural, and then another 35% with 3 to 5 categories. So I would say just a little over half would be either semi-rural or rural participants. So we did meet our goals. All right. We did an analysis of the first 94 people. We compared the Rook category. So our initial research question is, if we look at people that are more rural, so say 6 to 9 versus 1 to 2, and are they different? And what we found is that people who lived in rural settings tended to have more frequent seizures, which is consistent with the literature. Both more frequent seizures in the last 30 days, as well as more frequent seizures in the last 6 months. So it kind of really aligns with the existing literature that says that people with epilepsy who live in rural settings often tend to do worse. It's not entirely clear why that is, but most of the literature suggests that's probably due to less good access to care generally. So there are some clinician-facing service gaps. So in spite of the big body of evidence supporting epilepsy self-management for people with epilepsy, it is unfortunately not a current standard of care and not typically integrated into clinical workflows. Reimbursement can be challenging and inconsistent, so getting these services paid for is challenging. There are patient-facing gaps, so patients and families are not necessarily aware of programs like SMART. You guys, I would say, are an enlightened crew, right? You called into a seminar to learn about epilepsy self-management, but There are a lot of people who just never even heard that such a thing exists. There is still some problems with digital access, so many people still do have problems with web connectivity. And as I mentioned, we don't have a curriculum for kids and adolescents, which I think is still vitally needed. There are systems service gaps, so training epilepsy self-management providers takes time and effort. Keeping the program from drifting to be something else than its original intent is an ongoing and important effort. I have to put out big kudos to the Epilepsy Association for their willingness to invest into teaching their staff and their clients how to do this program. This is not cheap. It's not easy. It takes time. It takes money. And I have to give kudos to Patty Veronis, to Lisa Sobko, our other staff at the Epilepsy Association, for taking the time and trouble to not only learn how to do this, but how to do this correctly. So I really can't be appreciative enough of that, because I think you're helping our community. As if you didn't know that already, right? There are some silver linings that COVID has brought on. So in spite of the many, many terrible things and mortality and complications that COVID brought, one silver lining is that health systems now routinely use telehealth for healthcare delivery. People with epilepsy and a lot of other health conditions are used to seeing their doctors on videos now. So I think that's a good thing. That has helped programs like SMART become more acceptable to people. And then social media, which is responsible for a lot of negative things, a lot of harm, can also be used for good and to get the word out about programs like SMART. Thinking about the road ahead, I like to use the idea of diabetes as an example where I think we should be in the future with epilepsy self-management. So diabetes education is a standard of care in clinical settings, right? If you're diagnosed with diabetes, you get a referral to diabetes education, usually in conjunction with medication and other biological therapies like blood pressure, blood sugar monitoring, and insulin. Diabetes education or diabetes self-management teaches people how to stay healthy with their diabetes. They're led by certified diabetes care and education specialists. The diabetes educator help people meet their personal diabetes and other health goals. And as I said, it's a standard of care. Health insurance covers it, and clinicians know how to make those referrals. Diabetes education happens in either individual or group format classes, half an hour or 2.5 hours in duration. It's covered by most insurance, including Medicaid. And many health systems offer financial assistance for people who don't have insurance coverage or are underinsured to be able to access these education. So I think we need to have that with epilepsy self-management. So stay tuned. I also just briefly want to go through some ongoing work in SMART Scale Up. So I am involved in a project now with the Epilepsy Association here in Northeast Ohio, as well as with the Epilepsy Alliance of Ohio based out in Cincinnati, and the Epilepsy Association in Western and Central Pennsylvania. So we have a CDC-funded 5-year projects. We're coming down the pike with year 4, where the organizations have trained their staff to deliver the program. So I would say, if you know of anybody that might benefit from the SMART program, and you've heard a little bit more about it today, please reach out to the Epilepsy Association and they can help hook you up into this. We also have another project called the SMART RM project, where we are linking the SMART program with administration of an FDA-approved nasally inhaled rescue medication. So we're using a medication called Valtoco, which is used for cluster seizures. And we're about halfway through. So if you're somebody with epilepsy who is on Valtoco or Nasalam or one of the inhaled rescue medication seizure treatments, please do reach out to me. And Lisa can help link you up with me if you have questions about that. We also have a DoD, Department of Defense, funded project to adapt and preliminarily test the SMART program in adults who have brain tumor. So we're taking it beyond epilepsy. And then there's another project called the Expand Project. This is another CDC-funded effort to embed SMART into clinical care settings. And that we're doing in conjunction with investigators at the University of Iowa and at the University of Cincinnati. And I just want to give you just a real quick snapshot of what the Expand Project looks like. So this is not for community organizations like EA, as you have here that I talked about with the SMART program, but it's embedded in a health system and their electronic health record. So let me show you how it works. So number one on your left, a patient completes a surveys in MyChart. So that's the patient-facing electronic health record. They can use a tablet in the waiting room. They can use their phone. Many people do routinely access MyChart on Epic. And then a best practice alert shows up in the chart when the provider sees the patient and they see what the survey response looks like. If it looks like the person is a candidate for the SMART curriculum, the provider talks with the patient right at that time during the clinical visit to see if SMART is appropriate. If the patient agrees to participate in SMART, the provider clicks on that BPA alert to do an automatic referral to SMART, and the referral goes to a coordinator who schedules the person into an upcoming SMART group. And just as we did with the SMART 1 and SMART 2 project, SMART is delivered virtually by nurse and peer educators. So it's kind of a seamless process where people are seen in the clinic, they're screened for eligibility to SMART, and then they're automatically referred. So it's something that doesn't require a lot of manpower to get people referred to the SMART program. And then I just want to say a few other words about some of the work that I've done with the MU network. In addition to developing epilepsy self-management programs like SMART and Time, I've also running a archival data set where we're taking all of the research studies that the SMART network investigators have been doing since 2009 and pooling them into a legacy database. We had a bunch of publications. We probably got about 20 publications at this point. But one slide I just want to show you is one of the purposes of having this integrated data set where all of the data is pooled together is you can combine it and you can get big sample sizes. So this was a pooled analysis where we took 5 MU network studies that used different types of epilepsy self-management curricula, but they all had the primary outcome of the 9-item patient health questionnaire, or PHQ-9, which is depression severity. And what we compared is people that were in the self-management program, that's the blue line, compared to people that were in a control, so treatment as usual or wait list. And the PHQ-9 score, lower score is better. That means you have less depression. And what you could see is over time, over 3 visits, the people in the self-management curricula, no matter what type it was, had improvement in depression compared to those that were in control. So it really speaks to the success overall of the MU network and the positive potential impact of the self-management programs. I would not want to leave you without acknowledging our team. These are the faces of some of the individuals I've been working with. We have other folks who aren't on this screen, but it really takes a team. I know it's a cliche, but the teamwork truly does make the dream work. And so I'm grateful to all of the people that I work with that help us demonstrate that SMART works to help people. There's a few projects in the pipeline. I have a National Institute of Neurological Disorders and Stroke funded project testing an adapted version of SMART in a Ugandan setting, in Ugandans with epilepsy. And we continue to try to get funding for a testing of SMART in adolescents and young adults. So it's currently under review with the Thrasher Foundation that's invited us to submit a full proposal. Stay tuned. There is, of course, as I've mentioned, some funding uncertainty in the current federal climate. I guess I would just make a pitch for any of you, if you interact with any of your legislators or politicians, or you're at all involved in community activism. Hopefully I've convinced you that programs like SMART can help people with epilepsy. Research needs to continue and they need to continue to be supported. So I want to conclude with a quote from one of our SMART participants who said, "I learned a couple of ways to help that I hadn't even considered or known about. And since implementing them into my life, the number of bad seizure days I've had has gone down, which is really important to me." And that is a representative quote, but we get many, many comments from people with epilepsy that are aligned with that, that they find that they benefit from the support in the SMART programs and tools and tips and techniques that can help them manage not just their epilepsy, but their whole life. So let me stop there. And it looks to me like we've got about maybe 12 minutes. So
Thank you, Martha. That
take
was
it
an excellent
questions.
presentation. And I do have one question in the chat from Nicole. It's Harper's mom, and she says, "Hi, what can we do to promote the SMART program for pediatrics?"
Yeah. So we have SMART is not ready yet for prime time in kids and adolescents. As you know, kids are not small adults. They have developmental needs that are different from adults. Um, the Adult SMART program is mainly just focused on the person with epilepsy. We do encourage family members to join in and kind of have an observer role in our SMART groups, but they're not involved, I would say, in an interactive way in the groups. So we need to adapt this program for kids. And I would say, talk to funders, talk to your advocacy organizations. We don't need a lot of money to do our pilot testing because we've already done a lot already. It just needs to be tweaked for kids, but that's where we are now. And I would say the more you can talk with your pediatricians and kind of get the voice and the press out that this is really needed, I think, I've been in this business for almost 40 years. And sometimes change happens both slowly and then all of it, right? So you yammer away and you raise awareness and you speak out and you speak. It doesn't seem like things are happening, but you keep it on and you keep it on, and all of a sudden the tide turns and public opinion shifts, and we can actually force legislatures and politicians and health policymakers to say, this is important and we need to dedicate the time and funds for this. So that's probably a much longer and complicated answer than Harper's mom wants, but I appreciate the question and hopefully that's helpful.
Yeah, she actually had a follow-up. She said, "Are there any current programs for pediatrics from a neuropsychiatric perspective?"
So some of the Mu Network programs have been developed for adolescents. I believe the PACES program has an adolescent version. What I would recommend that you do is to go onto the CDC Mu Network, and you can find the contact information there.
Right. Any more questions? No? Okay, I don't see any more questions. Harper's mom said, "Thank you very much." If there are no more questions, we're ahead and conclude. Thank you for joining today's seminar. I hope you found this helpful and informative. We will be sending out a brief email survey at the conclusion of the seminar, so please keep an eye out for that. Additionally, I want to thank our sponsor again, SK Life Science, and want to note that the next upcoming seminar is scheduled for October 17th from 12 p.m. to 1 p.m. with Dr. Erbot, and I hope I pronounced her name, from Metro Health. She's going to be, her presentation is going to be epilepsy in the elderly population. So again, join us. That will be via Zoom.